እሺ ዶክተር በለ ነው እንዴ ጀምሩ ላችኋለሁ ስላለ እሱን እየጠበቅን ነበር። ጀምሩ አላለ። ገብተናል ገብቻለሁ። ከማጋ ሄሎ እንጀምር ነው እንዴ? ኦኬ እሺ ስታርት የሚለውን እየጠበቅን እሺ ታንክ ዩ okay, I think we are about to start. Thank you very much for being here in the room. Sorry, I was waiting for a start, like an announcement to start, but I think it was already there. I missed that. Apologies for this. So today we are back to the webinar series on COVID-19. I'm moderator of the day. My name is Adamo Adise. I'm an epidemiologist with a medical background from Addis Ababa University. And it's my privilege to be part of this session today. I will introduce the speaker of the day, and after that, we'll proceed to the presentations on the topic for the day, and we'll have discussions after that. The speaker for today is Professor Katao Demise. Professor Katao Demise is a dean and a professor in the School of Public Health at State University of New York, at the Downstate Health Sciences University. He is a senior and accomplished public health expert, and he's nationally recognized academician and a public health leader and researcher, especially in the fields of disparities and minority health, perinatal health, and cancer. And he has served in different positions prior to his current assignment. And he is heavily engaged in the current pandemic response and preparedness in the States. And he is sitting in the epicenter in New York at the moment, and he has first-hand witness. He's a first-hand witness of what has happened there, and he has been in the advisory council with the mayor of New York City. So it's really a privilege to have you, Professor Katao Demise. And now we'll have his presentation. He will be taking us through the updates on the epidemiology of COVID, entitled Coronavirus Pandemic, an Epidemiological Perspective, as is written in his slides. So thank you very much, Dr. Katao. So the floor is yours. You could also
Thank
say
you.
a few words about yourselves if you want to add about, specifically about what you are doing currently, and yeah, any additional explanation about your situation. Thank you.
Thank you for the nice introduction. I appreciate. Good afternoon, everybody. It is the afternoon in Ethiopia, and 8 a.m. in the United States. So I'm very happy that I have this opportunity to come and talk about coronavirus pandemic, which is happening currently globally. Originally, I was trained in Ethiopia. Actually, I'm a friend of Bada, and I was invited by him to come at this time. In Ethiopia, I served for a few years, and I was an epidemiologist in the city of Asab. There were some epidemics like cholera epidemic when I was practicing there. And I developed interest in community medicine. I went to the United States, Canada actually, before I came to the United States to get training in community medicine and epidemiology. Also, I got my PhD in epidemiology after my community medicine residency training, then moved to the States, worked at several capacities, including department chair, cancer center, population science director, and associate dean. And finally, I became the dean of the School of Public Health at SUNY downstate. But I also worked with the Canadian CDC while I'm in the United States, flying back and forth for about 2 years as a senior advisor to the Canadian CDC. They call it Laboratory Center for Disease Control. So let's start with our discussion. You know, when this pandemic started in this country, the first question people are asking is, you know, how long this disease is going to stay? Is it going to be over within 8 weeks? Is it going to be over within, you know, nobody expected that the disease will have a prolonged survival time. Everybody thought that it is a very short-lived disease. So in order to answer that question, it is important to understand what community immunity is or herd immunity is. And herd immunity is a protection that people actually acquire as a result of a high rate of immunity or infection in the population or in the community. And usually when the population infection level is very high, then the spread of the disease can stop. And the immunity level of the community can be high in two ways. One is if there is a natural infection, and if the natural infection in the community reaches a certain threshold and no more transmission of contagious diseases can happen. The other one is you can actually artificially induce it through vaccination or massive vaccination in the community. And the herd immunity threshold varies from disease to disease. This is a classic example where you can clearly see how herd immunity can prevent the transmission of the disease. So on the left side, you can see a lot of blue colored mane and a red colored person. The red colored is the infected person, and the blue ones are healthy people who are susceptible to develop the disease. But on the other hand, if you look at panel B, you see, in addition to the infected red person, you see the susceptible blue and the immune yellow people. What it means is, in the left panel, the infected person can transmit the disease to the susceptible population when there is no immunity in the community. But when the number of people in the community who are immune increases, as you can see, the infected red person will not be effectively to transmit the disease to the susceptible blue. It will not stop completely, but those people who are infected and those people who are immune, actually, already immune, the yellow ones, will block the transmission of the disease to susceptible individuals. So effectively, the immune people in the community will serve as a buffer between the infected and susceptible people, effectively cutting or blocking the transmission of the contagion or the infection. So that is dependent on, the transmission of the disease, what level of the population should have immunity to completely stop the pandemic or the epidemic. For example, if you take measles, one person can infect up to 18 individuals because measles is a very contagious disease. And the R0, or the basic reproductive rate of measles, is about 18. In other words, it's very infectious, and in order to really stop the spread of the disease in the community, close to 95% of the population should be immune to completely stop the spread. But for some diseases like COVID-19, the R nodes, or the basic reproductive number, is close to 3 or 4, which means it is less than measles, and we may not need 95% of the population to be immune to stop the spread of the disease, but at least we need close to 70% of the population to have the immunity to stop the spread of the disease. So to answer the question, when is this disease going to stop in this country or in other parts of the world, is it's only when the herd immunity or the community immunity reached about 70%. And that could be achieved through vaccination, massive vaccination, if there is vaccination. But unfortunately, currently we don't have any vaccine in the horizon. But probably the hope is that we may have vaccine around January of 2021. There are a lot of experiments that are going to produce vaccine, but vaccine requires a thorough testing. It has phase 1 or preclinical in animal models. Mostly they are using experiments in a rhesus monkey now. Then after that, it has to go to phase 1, which you will be testing it probably about safety in close to 40 people. Then you go to phase 2. In phase 2, safety and also efficacy testing is phase 2, and about 400 people can be involved, but from 200 to 400 people. Then you have phase 3, where you have a massive trial, and depending on the number of people, the time that you'll be following also varies. But in general, to really see the long-term effects of the vaccine, it will be advisable to at least follow patients for at least 10 to 12 months. That's why even if you do it in a very rapid way, and the approval process will be very rapid, still you need about a year to produce vaccine. So the short answer to when this disease is going to stop is probably it won't stop for the next 18 to 24 months. The disease will be with us. But if vaccine is effective, probably we can see tremendous reduction in the disease by 2021. Now, some people say, why not, if that is the case, why don't you why don't you leave people alone? Why do you want to put all this mitigation and other public health intervention in the community? Just leave it until we achieve the 70% herd immunity through natural infection if vaccine is not there currently. That has a lot of problems, and it's very costly, because if you just leave the disease to ride the course, one of the things is, compared to other diseases, the death rate of COVID-19 is very high. Although if you do, although we don't know the denominator, how many people are infected in the community, because we don't completely do a random sample of the community to understand the rate of infection in the community. Still, the mortality is very high. A lot of people who come into the hospitals, I will say of all the infected people, about 20% are admitted into the hospital, and a significant percent of these actually end up in ICU. And once patients are intubated, the probability that they die is very high, close to probably 80%. So if you leave the disease to ride its course, what will happen is a lot of people will be infected, and the healthcare system will not be sufficient enough to accommodate those people. The number of healthcare providers will not be sufficient, as it was seen in New York. And at the same time, equipments like ventilators, beds will not be really sufficient to handle the number of cases, adding to the death rate. So that's why it is important that we do mitigation and other kind of interventions to diminish the effect or flatten the curve of the epidemic, to prevent death, and also to prevent the healthcare system to be overwhelmed, from being overwhelmed by the disease. So those are the main reasons. Now, when we really think about this epidemic or pandemic, one of the things we need to think is, what is the best model that we have in the past we can actually base our predictions and our prediction of the course of illness and so forth. And in the past, there was the SARS epidemic, as most of you know, and also a MERS epidemic was there a few years ago. But none of these two diseases have epidemiologic similarities to COVID-19. And the course of COVID-19 is highly unpredictable. And every day we are learning new things about the disease. Yesterday, I got a report from the New York Department of Health at night saying, COVID-19 in children will present itself like Kawasaki disease, with the inflammation of the small vessels and involvement of multi-organ system. And about 15 cases in New York actually required intensive care units admission. And so the manifestations, the course, and everything that is about COVID-19 is unpredictable. Every day we learn new things. And, the epidemiology is not at all close to SARS and MERS. Although, when you see the sequences through the next generation sequencing, there is a lot of similarities between SARS and COVID-19. The epidemiologic manifestation is very, very different. And it is good to have a model because it will really help us to understand the course of the disease. Another comparative model is the pandemic influenza. And probably the pandemic influenza model is the closest we have to compare against the manifestations, the courses, and so forth of COVID-19. In the past, there were about 8 global influenza pandemics since the 1700s, and about 4 of them actually happened in the 1900, in 1819, in 1957, 68, and recently in 2009 and 10. And as you have heard, there is a lot of trials going on in the United States about convalescent serum to really prevent or diminish the severity of the illness now. And all those experiences were taken from the 1918-19 pandemic that killed a lot of people globally. So it is really important to learn about pandemic influenza, its actions both in the Northern Hemisphere and also in the global South, like Africa. And we know that the pandemic influenza actually affected the South in a major way, even more than what it did in the Northern Hemisphere because of lack of PPEs, lack of infrastructure and comorbidities related to malaria, HIV, tuberculosis, and other chronic respiratory diseases that are often common in the Southern hemispheres. So what are the similarities between COVID-19 and pandemic influenza? Number one, both of them are novel when they happened. When I say novel, what it means is the population susceptibility was very high and the community immunity was almost zero. So it is a virgin population where the disease can spread very, very quickly. That's a common thing between the two pandemics. The other is both of them have a route of transmission, which is respiratory spread through large droplets and also with significant spread with smaller aerosols. And at the same time, both the pandemics actually have asymptomatic spread. In other words, the disease actually spreads before patients develop symptoms, the typical symptoms of flu or the typical symptoms of COVID-19. The differences, on the other hand, between the two diseases is one is in incubation period. The incubation period for pandemic flu is about 2 days, whereas the incubation period for COVID-19 is about 5 days, which is significantly larger for COVID-19 as compared to flu. And the implication is when the incubation period is large, the incubation period is the time of the contagion entering into our system until the time we develop the clinical manifestation or symptoms. And that period, when that period is longer because of the asymptomatic transmission of the disease actually can spread effectively in the community before we do something about it. And a classic example is in the United States, in New York in particular, before we understand that the disease is spreading, it has really infected a lot of people very quickly. And that is manifested by the number of specimens that are coming for testing. And about, at the beginning, about close to 50% of the specimens or 60% of the specimens that were coming for testing were positive. We showed you that there is already, a substantial spread in the community before actually we understand that the disease is there. So COVID-19 has a longer incubation period, and it can effectively spread in the community without being noticed as compared to pandemic influenza. The second thing is the asymptomatic fraction. That is the fraction of people, the number of the community, the proportion of the community who will be asymptomatic before symptoms develop is much larger in COVID-19 as compared to pandemic influenza, which is about 15%, which means there is still more transmission without us knowing it in COVID-19 as compared to influenza. And in addition to that, the time period or the median viral shedding during the asymptomatic period is much higher in COVID-19, which is about 4 days, and about only 1 or 2 days for influenza virus. In other words, all these figures, as you can see, are really making COVID-19 more transmittable than the influenza virus. And the viral transmissibility is usually measured using R naught. R naught is used when the population is susceptible and virgin, but when the population is not susceptible, then the effective transmission rate, or RT, will be calculated. But the two figures are probably calculated in the same way. And they are noted the average number of new infections that will result from a single infected person in a susceptible population. And as I said, for measles, that number could be 18, but for mumps, probably about 12, and for COVID-19, we say that it's about 4. But R naught can vary depending on many factors. The mitigation things, the close downs, all those things can effectively reduce R naught because you are artificially restricting the transmission of the disease. So population density is also important, and it can also determine the R naught. They are not in New York City, where people live in close proximity in crowded apartments, may be very different from the R naught that you see in Texas, where people actually don't use public transportation and everybody drives his own cars, and houses are very separated, and the population density is much smaller. The same is true in the capital city of Ethiopia versus in the rural parts of the country. The R0 can be very different. So in summary, because of the longer incubation period, because of the more asymptomatic spread, and because of the higher R naught, COVID-19 appears to spread more easily than influenza, pandemic influenza. And as I said before, probably the disease will stay with us for the next 18 to 24 months and the transmission can be stopped when the population immunity reaches about close to 70%, either through natural infection or through the development and inoculation of vaccine to the community. And the evidence that pandemic flu in the past, whether it is dependent on season, I looked at the literature. The literature is very clear that the pandemic flu actually existed throughout seasonal variations. At one time, the pandemic flu that started in the spring, it persisted the summer and the fall. So it is very difficult to say that there is the seasonal variability of COVID-19 will be very dependent on the season. The other thing is the antibody protection. We don't know how much protection we'll have once people are infected, because in some of the coronaviruses, we know that the protection is short-lived. In some, it's longer protection. But one thing we know is if we follow a normal viral epidemiology, we would expect there will be some kind of immunity. Even if it is a short period of immunity, then a reinfection is likely to result in less severe illness. So that's an advantage that we expect. So the future course of the disease, I would say, it happened in the spring in China and in most of the countries, and it's very likely that we'll have a smaller waves of the disease throughout 2021. And that one scenario is in the summer, there may be a low-grade transmission, which could manifest in the fall and winter again with a large wave of new infections. That's one possibility. And if the mitigation efforts, which are stopped in most parts of the United States, continue, probably a low-level transmission without significant wave also can happen. So, I looked at, when I did this presentation, I looked at the rates in different countries, and you can clearly see that in temperate northern hemisphere and in the south, there is a huge difference in the rate of infection and in the rate of mortality. Like Ethiopia has a very low infection rate. The number of people that are tested, at least from the global website I saw, was really high, but the number of positive infections are very small compared to other countries, and mortality almost is non-existent. Obviously, the first thing that comes to an epidemiologist's mind when we see these differences between countries is the reporting, and the testing. How many people are testing? What type of people the Ethiopian government is testing as compared to what is being tested in the United States. So I don't know whether they are doing a population sample and do testing. Are they testing only those people who come through the airport? We don't know. I don't know. That will be a topic of discussion later for us. But depending on what type of testing they do and what type of facilities they have to be able to test a large number of the population, because currently we don't have the typical antigen testing that is used for flu and also like strep kind of thing. We use a PCR and detect the RNA of the virus, which is not very easy technique to have a high throughput kind of production that limits the testing capabilities of many countries. And Ethiopia is probably in worse situation compared to anybody like the United States because of differences in resources between the two countries. So that is one. The second is reporting. You know, China, for example, has a 1.5 billion people population. The United States has close to 300 something population. In China claims that they have only, you know, a tiny amount of number of people who are infected and who are dead, which I have difficulty to believe. But I'm not surprised because I lived in a communist country like China when I was in Ethiopia. So I know what goes into the reporting. In the hospital I used to work, it was pneumoconiosis was the number one killer in a report to WHO, where we never saw a case when I was there. So all the reporting, it could be a junk and also politically censored also. Both possibilities are there. I'm not saying that is true in Ethiopia, but we, as an epidemiologist, when we see, you know, these numbers, we should wonder all what is the likely explanation for all these things. The other thing is in this country, every death is registered. Nobody will be buried without a death certificate. But in countries like Ethiopia, uh, you know, birth certificates and death certificates are problematic. Birth certificates, probably you can get it by going to, you know, Kabbales and give some amount of money. They will give you whatever age you want to have, a certificate of that nature. But in terms of death certificate, it doesn't exist in Ethiopia. I don't know, maybe I left the country a long time ago. Maybe there is a practice of death certificate before somebody is buried now. But I doubt the mortality, the cause of death is clearly outlined. Even in this country, there is some problem about cause of death in the death certificate. So that could be one of the explanations for the differences we see between countries. But clearly, there is a divide between the northern and southern hemispheres, where the southern hemisphere has a much lesser disease and death rate compared to the temperate northern hemisphere. And I looked at the literature. If temperature is a factor, clearly there are 3 papers or 4 papers that are showing for each increase in degrees Fahrenheit or degrees Celsius, there will be for each increase in temperature, there will be a decrease in incidence and mortality. So the relationship is inverse between humidity and temperature and infection and death rate. And the other paper I looked at, actually, it is Bada who sent me the paper, differences in infection rate between very high altitude like Tibet versus Bolivia in South America, and clearly they were able to show that the rate of infection in a very high altitude country area is very low compared to a low altitude area, and they attribute the difference, number one, because the virus may not be virulent in a high altitude area. The second possibility is probably people who live in a high altitude area, their lung function, especially lung volume. I'm not sure about whether it is lung volume. I think it is the lung volume is likely to be higher because we have a great runners who can easily win. So their lung capacity is a much better condition and the infection may not harm them that much. But if that is a, yeah, that's another possible hypothesis that is likely to work, in countries like Ethiopia. So, uh, yeah, sorry about yeah. So we don't really, I don't really understand why, countries like Ethiopia has a lower rate of infection and transmission. The neighboring country, Djibouti, has a little bit higher number, but it could be, I mean, the altitude is obviously very low in Djibouti compared to Ethiopia, the rest of Ethiopia. Ethiopia, like the mountains in the capital city, are much higher altitude than Djibouti, which is probably at sea level. And on the other hand, the temperature and humidity in Djibouti is much higher compared to the rest of Ethiopia. So we need to really understand the effect of temperature, the effect of humidity, altitude, all kind of things, how it really affects the incidence and mortality of this disease. So I will talk a little bit about effectiveness of public health measures. One of the things at the beginning of the epidemic, where everybody was saying there is no need to have a community-wide mask wearing, but now there is a recommendation from the CDC and from other sources saying, oh, you need to have a mask when you go out, and most states have adapted it has a law actually, but I haven't seen a single clinical trial or randomized clinical trial comparing people who use mask versus who are not using mask to show its effectiveness. So it's an area of active investigation. Nobody is really doing that study, but it will be a nice thing to see how it works. But there are clinical trials comparing the different types of masks, the N95 versus the surgical mask. And those trials are not done for COVID, but they are done during the SARS epidemic. And clearly, the six small trials and their meta-analysis shows there is no statistically significant difference between the N95 mask and the surgical mask in the rate of contraction of the disease. So the other thing is, at the beginning, people talked about identification and quarantine, and now there is a huge effort in New York City and other places where the plan is to really train tracers for the identification and quarantining of people. And the assumption is the model of tuberculosis, the model of sexually transmitted diseases have been used to justify the rationale that this will be an effective way of controlling the epidemics. But the problem with the STD model is in STDs, it's very easy for people to remember with whom they slept with within the last 2 weeks, 3 weeks, 4 weeks kind of thing. But this COVID-19 is a little bit different. You go into a train, you go into public transportation, you go to a bar, and most of the people that you meet, you don't know. So the feasibility and the effectiveness of identification or tracing and quarantining people could be very challenging. And at the same time, the effectiveness may be really diminished significantly, although they are planning to spend a lot of money on it. So this is another thing which has not been really tested, but people just out of desperation, they are trying everything. The third element is, even if you identify the person, test it and positive person, then the issue is, what do you do with that person? Or he comes to the hospital, you release him from the hospital before the person is tested twice and become negative. Where do you send the person? They go back to their families and infect everybody in the family, particularly in areas like New York. People live in apartments, and they are usually crowded, and that is likely to be the case in countries like Ethiopia too, especially in the capital city. So unless you really have a separate place where you can really quarantine the sick people, the infected people, until they test negative, doing the testing and identification and just telling people to quarantine may not be that effective because of the living circumstance of people. Mitigation and shutdown obviously will work clearly, because you are effectively reducing the R naught by not allowing people to come close to each other. But how long you can do that in terms of vis-a-vis the economic effect it brings, it's a major question. But we have to really come up with a more focused kind of uh, mitigating the people, because even at one time during measles, when a group of people brought measles from another country, there were population pockets that developed the disease very, very quickly, in spite of the herd immunity, high herd immunity, because the herd immunity of a population, although it is very high overall, there may be pockets where the herd immunities are much smaller, and we can use that analogy to really develop effective measures at a smaller scale level to prevent the spread of the disease. So, but the mitigation and shutdown, uh, you know, interventions are clearly working, but the economic impact is devastating. Now we have probably 19 million unemployed people, and this number is going to continue rising. And if that is the case, probably we will go to a depression. That's why the government is acting and opening a lot of facilities now. And the other thing is, contact tracing is very labor intensive, and you need a huge infrastructure to do that. And in countries like Ethiopia, I don't know whether it exists now. There used to be health posts. Referral system starts in each Kavali. We used to have health posts who are staffed by community health workers. Then it goes to a clinic level, then hospitals. That was a referral system during the late 1980s, I think. So if that type of system works, that can be used for contact tracing, although as with the caveat that the STD model may not work for effectively combating, reducing the disease. I think that's basically what I have. I open it for discussion, and I'll be happy to respond to your questions.
Thank you so much, Professor Katao. That was really very illuminating and very rich presentation. It's a comprehensive presentation also, I would say, about the current pandemic. So you have touched several areas, starting from the basics of the disease up to public health measures and challenge associated with those. Um, so the floor will be open for any questions from the audience, and also I will raise maybe some questions as well as we go along. So maybe to start with, one question I have is about herd immunity. You mentioned that in the early part of your presentation. You said we'll be with the virus as long as we develop herd immunity. So the question is, how do we know when we have the optimum herd immunity? How do we quantify the level of herd immunity available? What are the techniques in place for that?
Yeah. So, the herd immunity, once people develop once people develop an antibody to the infection, you can test the antibody. There are several ways of testing it now. And although in the United States, there were 4 types which were approved by FDA actually gave a blanket certificate of blanket permission for the others to introduce the testing into the community, trusting what they said, what the manufacturers actually said. Now they are finding issues with quality, so they are really putting uh, stricter supervision and control measures to remove those tests that are not effective. So there is an antibody testing now. So the best way of really looking at if we have the herd immunity is to really a random sample is a good representation of the community. You don't need to really test the entire community, but an effectively done random sample through a stratification can really mimic what is happening in the overall community. As you know, when the sample size increases, you are coming closer to the truth. But if it is done uh, in a very random way using valid and sound statistical methods, the variability or the confidence interval, you can really develop confidence interval around the uncertainty. But for the most part, you can actually determine how many people you need in the sample to really estimate effectively and accurately the population parameter, which is the population prevalence of the antibody. Obviously, there is a certain threshold of the antibody that is required for protection. And you can see that what is the proportion of people with that threshold higher or higher than the threshold of the antibody level that exists in the population. So that's the only way you can determine, how much protection, how many people in the population have antibodies to decide the level of immunity. When that antibody threshold level, antibody prevalence is close to 70%, you can be sure that there is herd immunity and the transmission will decrease, definitely.
So this means we can base our models of projection on antibody tests. I mean, like there are these epidemiologic models projecting how many are infected and where are we in the curve. So can we base those models on these tests which you just suggested?
Yeah. So there are two, I think I saw a presentation somewhere by the New York governor. He's saying that he will use hospitalization and antibody testing and diagnostic testing, 3 combination things to really guide the transmissibility of the infection in the community, and he will base that, in reopening the state. But the truth of the matter is, the hospital admissions are about 2 weeks behind in tracing what is going on. The antibody is actually more than that. I would say it really traces what happened in the last couple of months. So if you do a community antibody testing today, most of those people who are positive to the antibody may have been infected 3 months ago or 2 months ago, depending on the level of protection the virus gives. So, but if you really want to know the transmissibility or the rate of infection, the R0, the R0, the best way to do that is to do a diagnostic test, which is, the PCR. We have now the PCR test that we use to see if the person is infected or not. That is a random sample of diagnostic test in the community, the one which will give you the rate of transmission, not the antibody. The antibody is mostly, useful in terms of really what percentage of the population is really had antibody or, immune, will not develop the disease. So the utility in terms of transmissibility of the virus is indirect. It's only useful when it reaches about 70%. You will know that the epidemic will not continue, but it will not really tell you the transmissibility of the disease.
Thank you. There are also some people who talk about cross immunity. Maybe infection to other corona virus species might mount some immunity to the current virus. I don't know if this is proven or it's just.
Yeah, I don't think there are studies that show that. There are a lot of theories saying that, infections like vaccination for BCG, vaccination for a lot of the diseases that we have in countries like Ethiopia may give protection or cross protection for COVID-19, but most of probably they look, like, for example, at one time I saw a study looking at the rate of allergy and asthma in the PPD test or BCG vaccination, and you can clearly see an inverse correlation. Those are very crude kind of analysis, and I'm sure the analysis we have mostly is very crude, but there isn't really sound studies that showed these things are protective at all. But cross immunity is a possibility. At one time, I heard the story that maybe chloroquine, which is often used in Africa, is preventing the spread of the disease and so forth. But there aren't really clear epidemiologic studies that showed that chloroquine is effective in blocking the transmission of the disease, or it can be used to really, reduce the severity of the illness. Although we are still waiting for a randomized trial, but the observational studies that came out on the use of chloroquine in the severity of illness were really not good, or they don't show any effect. But those studies are probably confounded by indication. In other words, what happens is probably the physician selectively will give the chloroquine or hydroxychloroquine to patients with severe illness compared to patients without who are with mild illness. In that case, those patients who are taking the hydrochloroquine are more likely to die. So that is a typical example of confounding by indication in epidemiology. But if you use a randomized control trial, then you can control confounding by indication. So we're waiting for the randomized trial to see if those treatments are even working. But there is no clear evidence, scientific evidence showing those type of protection at this time.
Thank you very much. You also talked about the possibility, that there is this theory of climate being a possible explanation behind why some countries are we see less of the disease. Also the north versus the southern hemisphere. Have you looked this in the US? I assume there are differences across United States, that some states may have tropical temperature and others have more northern hemisphere type of temperature. So
yeah,
is there
that's a good question. Go ahead. Sorry.
No, yeah, that was my question. Whether, since you have a very good surveillance system, it's a very good database available there. So was this demonstrated in the States? That was my question.
Yeah, that's actually a very good question, because yesterday I was thinking about that, because, if you compare different countries and show temperature and this and that, there are a lot of variables that will explain the difference in the infection rate, including testing, record keeping, reporting, all those type of things that we discussed earlier. So probably if you take only the United States and do that comparison within the United States, even in the United States, exclude the infection rate, because that is a function of testing, and different states actually do different testing. But if you compare mortality and at the same time be able to take the effect of or control for the effect of the different interventions like closures, lockdowns, and mitigation efforts that they are doing each state, then you can really effectively compare those states. That will be probably a better kind of study to do. And also we are coming for the month of May now, the temperature is getting hot here. So over time also you can look at the difference after taking into account the different control measures that are taking place, over time. So that's a good point, I think, to consider.
Thank you. I think another point which you raised was about the challenge of the public health measures, the non-pharmacological measures. And for example, lockdown, I assume there should be some evidence-based decision to be made, which measure should be instituted at what stage of the epidemic. But I think it has happened that in most African countries, some kind of restriction of movement, I don't know if that's a total lockdown, but some restriction of movement was instituted, even at a very early stage of the epidemic. And that had a big impact on the economy, I think, and many families are affected. So what your suggestion, not like having a complete lockdown or shutdown as had happened in European countries or in the US, in New York, Some said maybe a partial lockdown or a partial restriction somewhere in the middle. So what do you think about those measures? Do you think those have effects versus a complete lockdown? And also any comment on what evidence should drive those public health measures?
Yeah, I think the most important thing is the viral transmittability, which is are not. If they are not is significantly high in a population, then you have no choice except you have to really institute the mitigation factors, because already the infection rate is very high. You have no choice. Otherwise, you'll lose a lot of people, and the healthcare infrastructure will be crowded. So the transmissibility is the most important thing. But the viral transmissibility, it can happen all over the country, or it can happen in, areas of the country, in pockets of the country. So identifying where it is happening and really doing the intervention in those communities is the most important thing. And the other thing is, if the transmission rate is very low and the number of infections are for sure very low, then you can actually effectively try to do contact tracing, isolation. You need a lot of infrastructure and money to do those things, instead of completely locking down the country. The problem in the United States is because things can be done early, but we didn't know that the disease is already spreading in the country. That's why all these mitigation procedures, shut down and everything, are immediately implemented, because the R naught is already high. Without us knowing it in New York, the disease has been transmitting for some time in New York City, because, as I said before, the swabs that are really taken and that are coming to the lab mostly were positive, about 60%, which is a very high rate of infection. So it really depends, on the testing ability uh, of the country, and if you are able to do testing in different parts of the community to understand where the spread is. And if it is at early stage of transmission of the disease, you don't need to completely lock down the country. You can really focus on those pockets to be able to control, and you can manage it. A lot of countries were able to manage the disease without complete lockdown. So it's not that, oh, the disease is going to come, let me lock down the whole nation for 2 years. Then economically it will be devastating without really controlling the disease. So you have to be really systematic and strategic. And there are also different ways of testing the population. We use driving. People come driving to get tested. Walk-in driving, drive-throughs or walk-in testing is another one, which actually I put together a plan for walk-in testing in New York. So there are many ways of doing random testing in the community, which will tell you where the problem is, and you can really focus your intervention depending on the extent of the spread. Mitigation and lockdown is effective only if R naught is significantly higher than 1, and the transmission is already there. They have no choice. In that case, you have to lock down. But at early stages, you don't need to lock down the entire nation.
Thank you very much. That's really very helpful. So in Ethiopia, as you mentioned earlier on in your presentation, the number of cases we are having is few, and of course we have also few number of tests performed every day. But in the last few weeks, the number of tests being conducted have increased slowly. It's not optimum by any means, but still, I mean, the number of cases is still the same, being reported on daily basis is the same or small, and is against the projection we had when we started to have confirmed number of cases in early March. So yeah, so there is a big question of what's going on in Ethiopia. So are we not seeing the cases, or maybe we don't have much cases, or yeah, I mean, so this is a big question at the moment. Everyone is grappling with. Um, Also, there were some tests done randomly in the community, and so for example, there was a testing of 600 members of the community in Addis, and there was no one found positive. And most of the testings happen among those who are returning from other countries. So they will be put in an isolation, and they will be tested when they're symptomatic or when they are released from the isolation center.
Mm-hmm.
So that's how we detect actually most of the cases. I think 60% of the cases reported are from those situations.
Mm-hmm.
So what's your look into what's happening in Ethiopia?
Yeah, I think, testing the people who are coming from other countries is reasonable, but at the same time, that will not tell you the whole story. Actually, those tests tell you what is happening in the people's host
Other
country
countries.
rather than in your country. So, in terms of really, testing them and isolating people who are positive is not a bad idea, but it will not really tell you the extent of the spread in Ethiopia. So the best thing is to do a random sample in different parts of the country to see if there is a community spread or not. That will really tell you what's happening in different parts of the community. The other possibilities in Ethiopia, the temperature is hot now, and that may have an impact. As I said earlier, there is an inverse relationship between temperature and humidity, especially temperature and ultraviolet light, because Ethiopia is on the mountain, and the altitude also is another factor. All those things may really help for the reduced rate of transmission, but that doesn't necessarily mean you will not be able to see a higher rate of infection during the rainy season. It's possible that the rate of infection may increase in the rainy season, uh, and it's uh, it's very difficult, to say that if the rate of infection is quite low now, and if the rate increases dramatically during the rainy season, given the density in Addis Ababa and other large cities in Ethiopia, the infection can go very quickly. In New York, it didn't really take a lot of time to really to spread very fast in the community, especially when you have a large community, crowded population in cities. So I think for countries like Ethiopia, it's good that the infection rate is low, if it is true, but it is always good to do surveillance and check if that infection rate is really genuinely true in the community, and monitor repeated routinely or continuously to see trends in infection rate or death rate, and try to prepare a public health infrastructure in the event that it goes up. The government and the people can act or use to reduce the infection. That's the only thing I can say. But to be sure that the case is still low, then randomly sampling in a true random way, sampling the population and testing, and identifying areas where there is infection and act in those small communities at small level before it goes high. And assuming that the temperature is helping, a closer attention in the rainy season will be a good thing to really act in the event that the infection rate increases.
Yeah, thank you very much. So you also talked a little bit about mortality and how precise can we be in measuring mortality in a situations like Ethiopia. So you are right that we don't have days registration. Birth registration has started recently. So there is a vital statistics office in every qabale.
Good.
So, and it's now mandated by law that you need to register your kids and so on. So
That's good.
they have started granting a birth certificate. But days registration is still not happening really. And at Addis Ababa University, since I think 15 years, there was a small verbal autopsy surveillance. It's called a burial surveillance. So this is a surveillance of burial sites. So they randomly pick a number of burial sites and follow the pattern of days from the burial sites and go to the houses of the deceased a week after and do a little bit of interview to determine the cause of death. As you know, most of the diseases might have happened at home, might not have been in health facility. So it's in a retrospect trying to see what would have been the cause of death. And that surveillance has revealed that there wasn't much increase in mortality rate as we have seen in the last few years. I mean, the pattern and the seasonality was more or less the same based on the reports they gave recently. But other than that, when the health facility data was looked at in the past few months, there was increase in respiratory infections, generally like respiratory symptoms aggregated all together compared to the last 1 year. I think there is a twofold increase starting from November. But again, the data is very limited to know what was the exact cause of that infection and so on. And some people had the idea of maybe possibly we had some infection going around maybe starting from November, December, early January. But we don't have any much evidence to say what that was. Yeah, but mortality was not there.
Yeah, good.
Yeah.
That's very encouraging. At least you guys are doing, the verbal autopsy to determine cause of death. That's good. They used to do it a lot in India, so it's good to see that in Ethiopia, and it's very encouraging also that you have birth registration now. Yeah, so another thing which probably I didn't mention is syndromic surveillance that we use here in other parts of the world. That is, when you have limited when you have limited testing facilities, syndromic surveillance is another way of doing it. But in this country, there are certain infectious diseases that should be reportable by law, and the system of reporting is there. But in countries like Ethiopia, if you are using syndromic surveillance and detect that there is an increased rate of infection, flu-like or respiratory-like infection, then it's probably where you need to focus to do your testing and see if any of those things are related to COVID-19. Uh, it will really help to do testing in those aggregates of people who come with to the healthcare facility with some kind of respiratory illnesses. That also will give you a clue if you are able to do those type of things, surveys in hospitals routinely to see if there is an increase in respiratory infection. And the other big thing is, I don't know how many people will go to these facilities if the symptoms are mild, unless the symptom is really bad. A lot of people who are used to a lot of things in Ethiopia, they may just stay at home and not go to healthcare facilities. Maybe it has changed a lot, and now that people go routinely to see doctors' offices. I'm not sure how frequent that is, especially among people with low income and low socioeconomic status. I don't know whether they can afford to go and see a doctor for small things. And the other thing is, I don't know how many pharmacies are there in Ethiopia where people just go to pharmacies and buy over the counter medication for symptoms. So all those things can be targeted actually to see if there is an increase in respiratory infection as a way of syndromic surveillance, and do testing and understand if there is an increased rate of COVID-19.
Yeah, yeah, that's right. Just to add, recently the testing centers have increased. So in Addis, but also regional testing centers have been established, and so the government has a plan to further increase the testing capacity. And in parallel with that, testing is also now being conducted for individuals with pneumonia in all health facilities. So there is a mandatory reporting of pneumonia, and then all to be tested for this. And I think in the last couple of weeks, health extension workers in the community were trying to trace home visits and try to identify individuals with respiratory symptoms and high grade fever, and based on some criteria given at hand, linked those individuals to a testing facility as well. So I heard this is going to continue, and there is also a plan to do testing for all inpatients in all across. So this has started, I think, in Addis at least this week, and I have heard some reports of individuals who were identified as positives, despite the fact that they were asymptomatic for COVID. So this is what's happening, but we'll see how it goes. And there is, I think, a huge demand for testing kits and the testing machine, and making sure there are individuals very well trained for this purpose all across. So yeah, we have a limited resource country, so this by itself is a challenge. But I know the government is trying their best, and we hope this will be maximized in the coming months if it continued like this.
Yeah.
Yeah. So thank you very much. I think we have come to possibly an end of the session. Um, uh, so on behalf of the audience and myself, I would like to say very much thank you, Professor Katao. I have learned a lot, and I hope we'll also hear from you at some stage, and we'll possibly keep in touch. And I think one thing is clear that we don't know we don't know a lot about the pandemic, and there is a lot to learn in the coming days and maybe weeks. So we'll stay tuned, and maybe we'll tap on your expertise and your knowledge in the coming period.
Thank
So
you.
I will give you some time to say if you have any final word to or reflection or any key message to pass on before we end.
Thank you. I really want to appreciate, the opportunity to come and talk with, my country people. So I'm very happy that I do this. So I'll be always available to present new things that are coming in the field, and also, to do more collaborative research with you guys, and also to see if in any way I can help. If you guys face problem, feel free to contact me. I really appreciate it. Thank you for the opportunity.
Thank you, Prof. Yeah, we'll be in touch, and wish you all the best with your fight against COVID,
Thank you.
both in the US and for your help as well. Take care and have a nice day.
Okay. Thank you. I really
Okay.
appreciate it. Okay. Bye.
Bye bye. Ciao.
Okay.